We'll turn our attention here to the small intestine and some of the surgical problems that go on down there. The one thing I wanted to cover in detail, first and foremost, is the ever-important small bowel obstruction. This is certain to come up on the USMLE, and you're certain to see this in your practice, especially if you're an emergency practitioner. We'll also go over some of the neoplasms of the small bowel, both benign and malignant. Overall, they're relatively uncommon compared to neoplasms of the rest of the GI tract, but we'll just give them some attention here. And then the short bowel syndrome, which is a complication of extensive small intestine resection. So the small bowel obstruction is a blockage of the GI tract at the level of the small bowel, and most commonly in the United States it's due to surgical adhesions. People get surgery in this country for various reasons, abdominal surgery, be it for appendicitis, be it cholecystectomy, or even if you're getting pelvic surgery like a C-section. All of these surgeries put you at risk for adhesions, and adhesions provide nice sites for the small intestine to wrap around, and if it wraps around these adhesions too tightly, then material will not be able to pass through the small intestine distally onward to the large intestine. So surgical adhesions are the #1 cause of small bowel obstruction. It can also be related to the small bowel tumors that we'll talk about in a little bit. It can be related to hernia, especially femoral hernia. It can also be related to inflammatory situations such as inflammatory bowel disease. And then volvulus is something that is seen as well, especially in the pediatric population. The major complication we're keeping in mind, which we're always concerned about when there's a small bowel obstruction, and the reason that this can be deadly in some circumstances, is bowel strangulation. When we have bowel strangulation, we get ischemia to the bowel wall. Once there's ischemia, you can get necrosis, and that can result in peritonitis, ultimately causing sepsis and shock. In the pediatric population, there's some extra causes of small bowel obstruction, so congenital atresia, which you would see in newborns, pyloric stenosis, which is usually seen in infant boys, and intussusception, seen usually in newborns and toddlers. The symptoms for small bowel obstruction are what you would imagine for any kind of obstruction, so it's a cramping, sort of colicky pain, just like you would have if you had an obstruction of your biliary tract. It's a cramping, colicky pain. You can get nausea and vomiting, particularly nausea and vomiting if the obstruction is more proximal. You can also, in a patient's history, they may report diarrhea, but that's always, in the case of a small bowel obstruction, going to be followed by constipation and an inability to pass gas. Ultimately, nothing is going to pass the obstruction. And since nothing is going to be able to pass the obstruction, there won't be any stool left, there won't be any gas left. When differentiating where the obstruction is, not that it's super important clinically because we're going to be getting x-rays and imaging, but you can kind of put your finger on it. When there's a distal obstruction, that's usually associated with a more subacute, longer lasting pain and a much more severe abdominal distension. When it's a proximal obstruction, that's associated with more acute and severe pain because the obstruction is not very far after the stomach, and so those symptoms are going to come on rather quickly. And because of that, you can get vomiting because the obstruction is so close. There's not much room for everything to go, and you can also get bilious vomiting because the bile can reflux back into the stomach and then upwards into the vomitus. The labs that you're going to want to get whenever you suspect small bowel obstruction, or you've got really in general for acute abdomen, you'll want to have an abdominal x-ray. That's going to be very, very key for your small bowel obstruction. It's really the cornerstone of making your diagnosis. You'll want to have a CBC. CBC is important because if you have an elevated white count, especially if there's a left shift then that points you towards possibly strangulation, possibly ischemia going on. CMP is important as well. Normally with bowel obstruction, there's a degree of dehydration because you're not able to get nutrients through, and so you're not able to absorb fluid. And so what we would see in that case, elevated BUN and elevated creatinine. Also important to get the electrolytes because one of the differentials for small bowel obstruction from mechanical small bowel obstruction would be a paralytic ileus, which is something that we may see after surgery. And in those patients, they tend to have a hypokalemia, and so we would want to correct that. Amylase is important to differentiate out pancreatitis, and then the urinalysis, especially in women, and beta-HCG, just because we're going to be administering antibiotics to these patients. We're going to want to have that in any woman of reproductive age. If you can get an occult stool test, that would be recommended, just because if there is blood in the stool, then that raises your suspicion for strangulation. So these are all good labs to get in your initial workup, but the abdominal x-ray is what's going to help you with your diagnosis. So the best initial diagnostic test for small bowel obstruction is an abdominal x-ray, and you're going to want to get two views, both an upright and a supine view. And it's important especially to have that upright view because the upright view is going to show you air fluid levels, and that's really hallmark of small bowel obstructions. You'll also see dilated loops of small bowel. I mean, none of these things are perfectly specific for small bowel obstruction, but when you take it in consort with the history and the symptoms, these things are pretty accurate. CT and MRI are more accurate than abdominal x-ray, and certainly you can get a CT or even a barium swallow if you suspect small bowel obstruction, but the abdominal x-ray is equivocal or doesn't give you any findings that confirm your suspicion. But in most cases, abdominal x-ray will be sufficient, and that should be your initial diagnostic test. Once you've diagnosed small bowel obstruction, you should admit the patient and observe. You do not do surgery right away on patients with small bowel obstruction because mechanical obstructions usually tend to resolve themselves within 3 days. So what we're going to do is admit and observe them. We're going to place them on IV fluids because most of these patients are dehydrated. We'll want to decompress anything that's in their proximal GI tract, so we do that via an NG decompression. We'll also put them on prophylactic antibiotics to reduce any, if there does happen to be strangulation or if something is to happen down the road, we want to reduce the risk of sepsis. And so the prophylactic antibiotics that we give, we need to cover, remember, gram-negatives and anaerobes in particular. So ampicillin, gentamicin, metronidazole, those three will give you your broad coverage. And then an antiemetic would be good as well. So, as I mentioned, obstruction usually resolves itself within 3 days. If the patient has continued symptoms after 3 days, or if they start to show signs of a strangulated obstruction, and of course those would be peritoneal signs, development of fever, tachycardia, or if the pain starts to change where it becomes unrelenting as opposed to more colicky. And then, of course, also if within your labs you see an increased white count, elevating white count, then these things together suggest a strangulated obstruction. And this would be a surgical emergency, and in this case, the patient needs to be taken for resection. So here's an abdominal x-ray of a small bowel obstruction. This is an erect x-ray, and you see the small bowel that is before the obstruction here, and you see these lines here are air fluid levels. You don't need to give contrast. This will just naturally show up. So here's your dilated small bowel and your air fluid levels. And you see air fluid levels again with dilated small bowel. And more air fluid levels. One thing that I want to point out here is something that can help you differentiate small bowel from large bowel, apart from where they lie. The small bowel has these things. They're not house stray. They are what are known as valvulae conniventes. It's a Latin term. But unlike house stray, they actually go across the entire lumen of the bowel. So you see them here, these lines here. This is small bowel. With house stray, they'll be more further apart. So if you look back to some of the large intestine pathology x-rays, you'll see that those are more further apart. And then this is was actually a case of paralytic ileus. So paralytic ileus is something that can happen after surgery, especially if you've got a low potassium. And if you actually look, you can see where the surgery was done, and it's right here. And this is your fan and steel incision for C-section. So not uncommon to have mechanical bowel, quote-unquote, obstructions after surgery. Okay, so neoplasm of the small bowel, this is relatively rare, especially when you compare it to especially neoplasm of the colon, or even esophagus and the stomach for that matter. However, it is worth talking about. Most of the neoplasms of the small bowel kind of mirror the neoplasms of the stomach. They tend to be benign and asymptomatic, and so they're generally never discovered. We don't really have a way of looking at the small bowel with endoscopy. We can see the first parts of the duodenum with an EGD, and we can see the terminal ileum with a colonoscopy sometimes. But we really don't have any way of seeing the jejunum and the ileum. A way we can see it, if we really do need to see it, would be a pill endoscopy, a capsule endoscopy where you swallow the camera. But that's not done routinely like EGDs and colonoscopies are done. So most of these are never going to be discovered, even coincidentally. Symptoms of neoplasm in the small bowel, if they do cause problems, would include GI bleeding. They can cause obstruction, and then intussusception would be another possible result of a neoplasm in the small bowel. It is actually the #1 cause of intussusception in adults. Remember, if you have intussusception in a child, what are you thinking about? You should be thinking of Meckel's diverticulum. Other symptoms typical of cancer can exist if indeed the tumor is malignant, but to have GI bleeding or a small bowel obstruction or intussusception, you don't need to necessarily have a malignant tumor. That's just because of the mass that's there. But if you do have cancer, then you can have other symptoms not related to the small bowel, like fatigue, anemia, weight loss, that are just related to cancer, if you do have a malignant tumor. Malignant tumors have to be resected for a cure, but unfortunately by the time they present, they're usually too advanced, and any surgery that's done is generally palliative. And that's kind of in line with tumors of the stomach too, usually not discovered until it's too late. Okay, so some of the benign neoplasms of the small bowel, as mentioned, most of them are benign. Small bowel polyps should be removed and biopsied if you do actually find one. Usually you're going to find one either if it's in the duodenum, you can find one on EGD. Otherwise, you'll find it on capsule endoscopy. The adenomas can have malignant potential. They would go on to be adenocarcinomas. And the adenomas, just like for the colon, would include tubular and villus, villus being more likely to be malignant. And then Brunner's gland can be malignant, but it's the villus adenoma that's the most likely to be malignant. Hamartomatous polyps occur usually in the context of Peutz-Jeghers syndrome, which is one of the familial polyposis diseases. And Peutz-Jeghers syndrome itself does not cause cancer, but it increases the likelihood of cancer. So these hamartomatous polyps themselves are not cancerous. Removing them would do nothing to reduce the patient's risk of cancer. However, you you would see these in quantity with Peutz-Jeghers syndrome. Juvenile polyps occur in the context of juvenile polyposis syndrome. Those can be in the small bowel as well. Other tumors include lipomas and hemangiomas. But I don't want to talk too much about these neoplasms because they don't come up too much on the test, and even in real life, they're not really common. Okay, so the malignant neoplasms of the small bowel include the gastrointestinal stromal tumor. Gastrointestinal stromal tumors are not always malignant. About 10 to 20% of them are malignant. If they are found, they're most commonly found in the ileum, which not the easiest place to visualize. Some of the symptoms that can come out of the gastrointestinal stromal tumor would include bleeding, first and foremost. So this is a tumor of the connective tissue. The treatment for this would be resection as well as imatinib. But just like with the stomach, resection is the forefront of your therapy for stromal tumor. Adenocarcinoma of the small bowel would be like one of those progressed villous adenomas. If it progresses into adenocarcinoma, this makes up about 40% of the neoplasms of the small bowel and the malignant neoplasms. And this is most commonly found in the duodenum or proximal jejunum. And again, not a very easy place to visualize, and so usually it doesn't. You don't see it until it's too late. The treatment here is a Whipple's procedure, which is where you take out most of the pancreas as well as portions of the duodenum. You can also do palliative stenting if there's a blockage. Carcinoid tumor actually can present with symptoms before it's too late. So with carcinoid tumor, it can present with specific symptoms because the carcinoid tumor secretes serotonin. And so you can get what's known as carcinoid syndrome. Not all patients with carcinoid tumor will develop carcinoid syndrome. However, the patients with this carcinoid syndrome, with flushing, wheezing, and diarrhea, these three things together, they should be evaluated for their serotonin levels. And we're not really actually measuring serotonin, we're measuring the byproduct of serotonin. That's 5-HIAA, 5-hydroxyindole acetic acid. And if those levels are elevated, then we should be checking the patient for a carcinoid tumor. Typically, the carcinoid tumor is found in the appendix, and if it is found in the appendix, then you're probably not going to get any blockage of the small bowel. However, it can also be found in the ileum as well. Usually, if it causes carcinoid syndrome, it's going to be in the ileum. Carcinoid tumors in the ileum are more likely to spread to the liver, and it needs to spread to the liver in order to cause carcinoid syndrome. So the treatment for carcinoid tumor is resection. For acute symptoms of carcinoid syndromes, you can administer the patient octreotide or cyproheptadine. So cyproheptadine is a serotonin antagonist, and octreotide is a somatostatin analog. Okay, and then small bowel lymphoma, just like in the stomach, this is a non-Hodgkin's lymphoma. It's B cells. This makes up about 20% of malignant neoplasms of the small bowel. There's an increased incidence in immunocompromised patients, as well as those with Crohn's disease and celiac disease. So patients where there is chronic inflammation of the small bowel puts you at risk for small bowel lymphoma. The treatment here is going to be resection, and then if there is disseminated disease, then you're going to treat them with chemotherapy. And for non-Hodgkin's lymphoma, we tend to use the CHOP chemotherapy. And the CHOP stands for cyclophosphamide, hydroxydonorubicin, which is adriamycin, oncovin, which is vincristine, and prednisone. So CHOP. And then the R, you can add rituximab or not add rituximab. It's really at the discretion of the oncologist. But you should know that CHOP is the therapy for most to all of non-Hodgkin's lymphomas, which small bowel lymphoma is one of those, as well as the gastric lymphoma. So short bowel syndrome is a complication of surgery. So there are patients who require resection of their small bowel. And when you think of what patients those would be, it would be things like Crohn's disease, which you can get disease of the small bowel. If they need resection due to a stroke of the bowel, so like mesenteric vascular ischemia. If they're patients who have gotten radiation to the abdomen for a tumor, you can get enteritis from that, and that can damage the small bowel. And then in pediatric patients, there's neck. But with adults primarily in the U.S., this is going to be due to direct surgical resection of small bowel. So what happens is when you get enough, and it's not really, there's not a set amount that's the same for everybody. Certain patients, if it might be less than others, but once you've resected enough small bowel, you'll start to have symptoms because you don't have enough small bowel to absorb nutrients that you're getting. So fats, vitamins, electrolytes, sugars, and so forth. So this is really a complication because you don't have enough space to absorb your nutrients. The symptoms are going to be malnutrition, of course, because you're not absorbing fats, which is where we get most of our calories, weight loss, which is a direct effect of the malnutrition, steatorrhea, because there's fat going into the stool. Abdominal pain can be related to gas because the bacterial flora in the large intestine are digesting the nutrients, and then symptoms related to vitamin or mineral deficiencies. Particularly, one to keep an eye out for is B12 deficiency, especially if you've had to remove parts of the terminal ileum. The diagnosis for short bowel syndrome is usually pretty straightforward because the patient has a history of extensive small bowel resection or damage, and now they've got malnutrition. Treatment is going to be adequate oral nutrition, which means they're going to have an increased caloric intake to make up for the fact that they're not absorbing as much a percentage of the calories that they're taking in. So they'll need to increase their intake. Vitamin and mineral supplementation should be provided. This can be oral or parenteral. And then antiperistaltic agents are useful as well. That's like loperamide, that just slows things down in the small intestine. And if adequate oral nutrition can't be attained, then there is a procedure to reverse a segment of small bowel, and that should say increases transit time. It slows things down in the small bowel, so it increases transit time. And there's other operative techniques as well, but this segmental reversal of small bowel is performed rather frequently. Now, another way you need to think of small bowel syndrome is in the acute case. So patients who have just previously undergone small bowel resection are going to have problems with nutrition and fluid balance in the short term because the small bowel takes time to hypertrophy and so that it's got more space to absorb. So in the direct postoperative period, patients who get small bowel resection are going to usually need to receive total parenteral nutrition. And over time, the bowel will hypertrophy, and you'll be able to transition slowly onto oral nutrition. Important parameters you need to look for here, or really in any case where you've got small bowel resection, is electrolytes and urine output. That just demonstrates the electrolyte metabolism and the fluid balance. And serum albumin, which is a great indicator of the patient's nutrition status, and then weight. Some patients, it will be difficult or impossible to transition them to oral nutrition, and these patients usually have a pretty bad outcome. Complications of total parenteral nutrition, and of course these complications are going to be worse and worse the longer they're on total parenteral nutrition, include liver problems, cholestasis, non-alcoholic steatohepatitis, or NASH, venous thrombosis at the site where you're injecting for the parenteral nutrition, and then of course any time you've got repeated injections, you can cause infection as well. But the important thing to remember about short bowel syndrome is that in the acute phase after small bowel resection, you're going to have to put the patient on total parenteral nutrition and then wean them off so that you don't have this malnutrition. However, some patients in the long term will continue to have these symptoms, and it's important to pick that out because these patients, you'll just need to increase their diet, increase their caloric intake, make sure that you're supplementing their vitamins and minerals, and then there's some other techniques that you can do, either medical by giving these antiperistaltic agents or surgical via small bowel reversal.